We'd like to open it up to questions, if anybody has any questions for any of our panelists.
I have a question for Dr. Reeves. Dr. Reeves, I spoke to a radiation oncologist yesterday, and they thought the findings were great, but not, I mean, they say regular radiation, they don't tell their patients the side effects are as bad as you're saying. They're saying that people go through it just fine, and so why really is this so much better?
Right. It's a great question, and I'm actually going to let Dr. Bush talk mostly about that because he's a radiation oncologist and he sees the actual side effects. But I think that one of the things that I have become convinced of over the years is that as physicians, when we see individual patients, we broadly think that they do well, and we kind of minimize the side effects that really happen. But when you subject those treatments to trials, follow these patients rigorously over long periods of time, you actually find a significant number of very important side effects, much more so than when you're just looking at the results anecdotally in individual patients. And so following over a period of time and in a rigorous way, you do see significant side effects from this. And again, that is one of the things that was strikingly apparent in this trial, is that the side effects were much less than would be expected. I'm going to have Dr. Bush talk some about that also.
Yeah, as Dr. Reeves alluded to, the kind of side effects that can happen with this kind of treatment they don't happen terribly often, but when they do, they can be quite substantial. Exposure of the heart to radiation is known to potentially cause heart attacks later in life, and that's obviously serious. Rib fractures is well known to happen. Secondary cancers can occur years after treatment. I think we know those things happen, and I guess I would say that perhaps those things aren't emphasized enough because a lot of times those things happen so much later that we kind of forgot that they're related to the original treatment that they had. Really, the concept here is we shouldn't be radiating tissue that doesn't need to be radiated, and unless there's a benefit to radiating any part of the body, we shouldn't be doing it, and that's what we have done here, is saying, look, we're only going to radiate the area that we believe really needs to have it. All the surrounding areas are going to be protected from it because we feel like they don't need to be treated. So it's really just a way to make the radiation go to where it's most important and eliminate the exposure to other parts of the body to possible harmful effects that can happen later on.
There are other forms of radiation that are more targeted. At least the doctors say that, and they have these side effects, and they say that they're just as precise. I don't know as precise as a proton.
There are other techniques used that are in use at other centers to do this type of treatment, but if you compare how they do it, there's nothing that does it better than proton beam, meaning this notion of not radiating tissues that don't need to be radiated. Comparisons have been done with these other methods, certain forms of photon or X-ray type treatment, IMRT, those kinds of things don't do it as well as you can do with proton beam, and that's already been shown in the literature.
Proton beam is not an X-ray?
No, it isn't. It's a type of radiation, but it is distinctly different than X-rays. These are small particles that can penetrate into tissue to a certain depth, and they stop. And I think that's what's shown in the diagram here, where that top frame shows how X-rays, kind of shown in that yellow cloud, would pass basically all the way through the body, whereas a proton beam on the bottom is a beam that can be directed straight to the tumor, and it stays there. It doesn't continue beyond. And that's why basically any comparison you make with protons compared to X-rays will always show an advantage for proton beam because of that because of that action. That's something that's very unique to proton beam. X-rays don't do that. They always go all the way through.
Other places should get a proton beam, and not everyone has one.
Yes, I do.
I have a question for Vicki. Vicki, you were telling us that one doctor said that you should get a mastectomy because the radiation treatment would be too harsh.
That was my cardiologist, and that's because about 15 years ago I had aortic valve replacement, and he was afraid the radiation would be too close to my heart. And having a bad heart already, you know, he was afraid that I would get more damage, and so if I had a mastectomy, I wouldn't have to have radiation or proton.
So were you considering that?
No, that was not an option for me.
This was much better.
Proton, yes. Absolutely.
So Vicki, you would like go to lunch or get a treatment before work, or have it go right to work? Or?
Yes, I went to work in the morning, took my lunch hour, and came here and did it, and went back to work. I felt fine.
Not lightheaded or dizzy or nothing you said about it?
No side effects. The only thing, I just got a little bit of a tan in my breast, but that was it. It was not red or rash, nothing like that.
How old were you when you had those heart valve replacements? Pretty young.
I had it when I was 33 years old or 37, I don't remember.
So that it was a good, 5 years before, 10 years
I think it was about 10, 13 years before.
before the
Yes, right.
The second, you said you've opened up the eligibility. So, what's it open for?
The current guidelines that are in use for patients who might be eligible for partial breast treatment in this fashion are still kind of being established. So what we've done with the new trial is taking some members of the group that have thought to have been perhaps borderline candidates for this kind of treatment and kind of use it in those situations so that we can kind of gather more data to see what the results actually are. So we're hoping at the end of the second trial to be able to know whether we can safely expand the indication for this kind of treatment into that group of patients.
Like second stage cancer?
So what did you tell them?
It's this kind of subgroup that's kind of in the gray zone would be patients with what we call ductal carcinoma in situ, tumors that are a little bit larger in size. Sometimes the surgical margins or the periphery of the surgical resection is perhaps not as widely clear as you might like it. So we think that perhaps some of those patients could be treated in this way. So those are some of the patients that are now included, which would not have been included in the original trial.
Were any of the patients, did they have that gene? Is it BRC?
No, yeah, none of those.
They would have been excluded.
They would be excluded, that's right.
If there are no other questions for our doctors, that's pretty much it. But I believe our group is going to be here for a few minutes. I know our physicians have to go back to clinic, but if you'd like to get a few moments with them on your own, feel free to do so. Thank you so much again for coming.